Hello, my name is Bryan Naelitz, and I'm a rising senior at Amherst Steel High School. This summer I participated in the Science Internship Program, and I was placed at Lutheran Hospital in the Orthopedics Department. This summer I did research on patient-perceived quality of life following total shoulder arthroplasty. To further understanding, I would just like to detail some background information. When one generally thinks of the shoulder, he or she is thinking about the glenohumeral joint. It's a ball and dish joint that is composed of the articulating surfaces of the humeral head and the scapula's glenoid. The deltoid, trapezius, and rotator cuff muscles surround this joint and, in conjunction with the bones, provide support, structure, and mobility. There are a few conditions that may warrant the possibility of surgery. These are osteoarthritis, rheumatoid arthritis, cuff tear arthropathy, contained and non-contained cuff tear arthropathy. The image shows osteoarthritis. Shoulder replacement involves the removal and replacement of damaged tissues with prosthetics. The goals of surgery are to decrease patient pain, improve quality of life, and augment range of motion. Surgery is truly a last resort and should only be considered after pharmaceutical and therapeutical options have been explored before surgery. Because surgery induces bodily trauma, necessitates a long recovery, and elevates the risk of hospitalization and infection. Shown in the picture to the left are variations of stemmed implants. On the right, there are two resurfacing implants alongside another stemmed implant. There are four types of surgeries that are considered in this study. The first is total shoulder arthroplasty, followed by reverse total shoulder arthroplasty, followed by cup hemiarthroplasty, and then revision. These X-ray images show the total shoulder prosthetics. In a total shoulder, a stemmed implant replaces the humeral head, and the glenoid is either resurfaced or replaced with the cup. Surgery is typically performed on older and less active patients that have an intact rotator cuff and deltoid. These are X-ray images showing the reverse total shoulder prosthetics. In a reverse, the scapula is mounted with a semi-spherical implant, and a stemmed reciprocating implant replaces the humeral head. Surgery is typically performed on older and less active patients that have a deficient rotator cuff and deltoid. The picture on the left shows a cup resurfacing implant, and the picture on the right shows an X-ray image of the cup hemiarthroplasty. In a cup, the humeral head is either resurfaced with a metal implant or is replaced with a stemmed implant. This is a conservative type of treatment that is typically performed on young, active patients that have an intact rotator cuff and deltoid. Following surgery is a lengthy 4-month recovery and rehabilitation process. The goals are to maintain motion achieved at surgery, rehabilitate muscles within a functional range group, and to train the body for maximum performance. Patients will continue the therapy at home and will see full results after 1 year. Now onto the research and methodology. Before the study was designed, Dr. Seitz noticed that almost no literature exists that concerns what truly matters following surgery, the patient-perceived results. This is why this study seeks to evaluate the patient-perceived effectiveness of total shoulder replacement. The study's goal is to investigate how differences in patient demographics affect the perceived quality of life. The study will compare procedural types, etiologies, post-operative times, activity ratings, and patient demographics with one another. The study's hypothesis was that patient-perceived quality of life will continually improve as post-operative time progresses. A standardized survey was developed that asked patients to self-rate their perceived difference in ability and quality of life following surgery. Before the surveys were administered at 2 Cleveland Clinic locations, the RB had to grant approval. Patients were asked to rate post-operative activity levels, satisfaction, benefit, and report whether they would retrospectively have the procedure done. The patients were asked to rate activities on a scale of -5 to +5, in which -5 represents a significant negative effect and a +5 represents a significant positive effect. A standard of 0 represents the patient's preoperative performance in each study. Thus, the patient's stand is their own standard of comparison. Many patients completed the survey multiple times. All the surveys were entered in Microsoft Excel 2003 and were organized by procedure type and etiology. Later, they were broken down by post-operative timeframes. Measures of central tendency were performed on the surveys, and a statistician revealed the relevant results. The results that follow are all significant because they have a p-value that is less than 0.05. 274 patient surveys were collected, in which 142 patients completed. 77% of the patients were female and 65% of the patients were male, which the graph below shows. The average patient age was 69.282 years. These graphs show the etiological and procedural patient distribution. Many patients were sorted into multiple etiological groups. A significant portion of older patients tended to have osteoarthritis. Many patients unknowingly had an RCT and were sorted into the CTA categories. This data table simply displays the activity averages in correspondence to the procedure. The highest values were highlighted in green, and the lowest values were highlighted in red. This is another data table that simply displays the activity averages in correspondence to the patient's etiology. The highest values were highlighted in green, and the lowest values were highlighted in red. When analyzed by procedure, we found that the TSA was the surgery that gave patients the greatest benefit and satisfaction. Over 91.4% of patients reported being satisfied, and over 97.1% reported benefiting. The average activity rating was a positive 3.06. Cup arthroplasty was the surgery that gave the patients the least satisfaction and benefit. Only 64.1% reported being satisfied, and only 88.1% reported benefiting. And there was a pretty low 1.16 activity rating. The graph shows that TSA, represented by the red bars, has the highest activity ratings for a plurality of the activities. CUP, which has the total negative averages for both hobby and leisure groups, has the lowest rating for each activity category. This graph shows that patients who received a total shoulder arthroplasty have the highest levels of satisfaction, with over 90% reporting satisfaction. Patients who received a cup had comparatively low satisfaction ratings, for only about 65% reported satisfaction. RTSA and revision patients reported moderate levels of satisfaction, with about 83% of patients reporting satisfaction. When analyzed by etiology, patients with rheumatoid arthritis and osteoarthritis perceived the greatest improvement after surgery. For the RA group, activity ratings averaged a positive 4.16, which is significant because this study was only on a -5 to +5 scale. 97.5 and 93.4% respectively reported benefiting and being satisfied after the operation. Cuff to arthropathy contained and non-contained perceived the smallest improvement. Only 1.83 and positive 2.64 respective activity ratings were reported after, and there were low levels of benefit and satisfaction, with only 90.3 and 83.7%. The graph clearly shows that rheumatoid arthritis, represented by the light blue bars, has the highest activity ratings for each activity. It also shows that CTA contained has the lowest activity rating for each activity. This graph shows that the patients with OA and RA etiologies have high satisfaction ratings. It shows that both CTA contained and non-contained have comparatively low levels of satisfaction. When analyzed by time period, we saw that patients initially perceive a lower quality of life following surgery. As time progresses, the patient's activity quality of life only increases, significantly at first and then gradually later. In a majority of cases, the 0 to 6 week time period has the lowest average activities. Also, in a majority of the cases, the greater than 2 year time period has the highest average activity ratings. The data table displays the average activity ratings over time. It shows that patients initially perceive a negative activity rating of -0.0177, and that over time this rating improves to be a positive 3.917. The graph shows that TSA activity ratings over time. The graph shows with the purple line that the 0 to 6 week time interval has low positive and low negative activity ratings. As post-operative time increases with the red, yellow, green, and blue lines, the rating increases to a value of approximately 4. Results by activity. We found that bathing, eating, sleeping, and dressing benefited the most from surgery. Activity ratings were all above 2.81. Driving, writing, interacting with family, and performing chores improved modestly, with activity ratings above 2.53. Leisure work and pursuing one's hobby improved the least, for average ratings were below positive 2 and were as low as 1.343. The data table above displays the total activity averages, and the graph below shows that TSA activity averages across time. Both show the results that were mentioned in the last slide. The graph shows that even over time, the activities perceived as most improved are still highest for their respective time intervals. Overall, it was found that 94.3% of patients strongly benefited from their surgery. 89.1% of patients strongly agree that they are satisfied with their surgery. The graph to the right shows that over 90% of patients across all procedure types would have had their surgery done again. An overall average of 96% of patients would go through the pain, recovery, and lengthy rehabilitation again after they consider their post-operative results. This slide shows some patient testimonial. Patients typically report these type of comments, and it indicates that their life has improved drastically, such as, I'm enjoying life again, even housework. I feel better about myself. I'm no longer a cripple. In conclusion, it was found that the hypothesis that patient-perceived quality of life will continually improve as post-operative time progresses was shown to be correct. We also found that an overwhelming majority of patients experience a strong positive effect after all types of shoulder replacement. Patients perceive an enormous increase in their quality of life, are satisfied with their surgical results, and feel as though they have benefited from surgery. We found that after surgery, patients can lead lives with less pain, can be more active, continue to work, and engage in their hobbies. We concluded that the benefits of surgery are felt long after the initial operation, and saw that some surgeries, such as the total shoulder arthroplasty, benefit the patients more than other types of surgery, such as the cup arthroplasty. We found that patients should expect significant improvements in some areas of their daily life, such as bathing, and little improvement in others, like work and leisure. Etiology affects patients' post-operative satisfaction, which we found when comparing the RA and OA scores to the CTA contained and non-contained scores. But one has to understand that patients get these surgeries for different reasons. Now on to the discussion. The study contained many categories in which there were not enough patients for the collected data to be analytically significant. So as the study continues longitudinally, patients will be added to all etiological and procedural groups. Specific patients were not consistently followed at regular time periods, which warrants the need for participants to be examined consistently and at regular intervals. The results and conclusions reached with the study can now be comprehensively presented to the patients considering shoulder replacement. This would give patients a chance to know what could reasonably result from a particular type of surgery and how their lives could be specifically impacted. Thanks goes out to Dr. William Seitz, my mentor. Also to Allison Barley, my co-intern, to Nedra Starling, Rosalind Strickland, and the Office of Civic Education Initiatives. To Dr. Seitz's office aides, Maureen and Mary, to Dr. Yuji Umida and Ernest Michaud, who helped design this study, and also to the staff at the Lutheran Hospital and Beechwood Surgery Center for their help and support. Thank you.